All right, so it looks like the video that I gave you does not have the OMD portion, which is unfortunate for all of us. So, um, I'm gonna record this, and we're gonna see how it goes. I'll probably be clearing my voice a lot, so I don't know if you have misophonia. Um, don't listen to this very loud, I guess. Okay. Um, so let me see. I might need to adjust the volume a little bit louder. It's pretty good. Okay, so what is OMD? OMD stands for orofacial myofunctional disorders. And basically, orofacial, so oro meaning mouth, facial meaning face, myofunctional, myo is muscle, and then functional is the function. So it's mus disorder of muscular function of the mouth and face. So there you go. Um, a lot of these are characterized by tongue thrust, which you know from the lab. Sorry, I had to take a drink. Tongue thrust, which you know from the lab, which is pushing the tongue a little too far forward when you're at all times, but especially when you're eating or drinking. Uh, Immature swallow or reverse swallow is essentially the type of swallow that you have with tongue thrust. We'll take a look at some of those in a minute. So it's okay if that doesn't make a lot of sense. Anterior positioning of the tongue is just where you're carrying your tongue at all times. So it's not up along the roof of your mouth. It's kind of like hanging out over the bottom teeth. These are all basically the same thing. All of them are the same thing. It's just that anterior carriage of the tongue is going to happen when you're not doing anything. Anterior positioning of the tongue is going to happen when you're talking. Tongue thrust is going to happen when you're drinking. Immature swallow and reverse swallow are going to happen when you're eating. Well, or drinking. So it's all the same thing. It just happens at different times. We talked about this. It's a disorder of muscle function of the face and mouth, mostly related to placement of the tongue. And why? Why does it happen? Abnormal thumb sucking habits, also finger, lip, and tongue sucking habits. We'll talk about why in a minute. Inappropriate mouth open posture. This is usually for help in breathing, but again, we'll talk about all this in a second. Allowing the tongue to rest in a forward position, um, and tongue thrust during speaking and swallowing, which we already talked about, and we'll talk about again. So these are all reasons why OMD might happen. Okay, so let's talk about some of these uh, in depth. So we've got behavioral oral habits and then also restricted frenulum. Frenum or frenulum, these are both acceptable words. They mean the same thing. Um, and they're both used in medical terminology. So I'm not sure why we have two words for it and why they're so close to each other, but they are both used. Then there you go. There's a word lesson for the day. And then also adaptation to restricted airways. Let's look at these oral habits first. So this kid sucking on his thumb or her thumb, not really sure. It's hard to tell with babies. Doesn't matter. It's sucking on his thumb. Um, it doesn't have to be a thumb. It can be a toy, it can be a pacifier, it can be thumb, it can be fingers, it can be a sippy cup, all of this, or a blanket. But basically, if there is something in the way of the tongue, you basically the child learns that the tongue doesn't go up on the top of the mouth. It doesn't lay across the top of the palate. Not the top of the palate. The top of the tongue doesn't lay against the bottom of the palate. It doesn't lay on the hard palate. So this is a behavioral learning. You could take somebody who has no issues and no muscular issues, no also cartilage and bone issues. They start out totally fine, and essentially they just learn that their tongue doesn't go where the tongue is supposed to go, which is again resting against the hard palate. So as they learn this, then even when they don't have things in their mouth, the tongue just kind of rests along the bottom of the mouth. So there you go. And then this will have effects later on. We'll talk about those effects in a minute. Um, Sippy cup and pacifiers, um, these are all going to do it. Anything that's in the mouth, just like I said. So, what are some um, alternatives to a sippy cup? Well, there's a couple of these. So, if you have a kid, or you think you're going to have a kid, or you know somebody with a kid who uses a sippy cup, you can send this slide to them. I don't know why these work so well. That's because I don't spend a lot of time around kids. But um, I know the purpose is so they can't spill stuff. Kids are so clumsy. Um, they're like drunk people. And so the sippy cup is there so if they it, if they knock their cup over, it doesn't go everywhere. And so presumably these are also new designs of a cup that doesn't go everywhere. Uh, but doesn't have the same problem of obstructing the tongue from a normal position of drinking. Okay. And here we go. The restricted frenulum or frenum, same thing. So these are all pictures of tongue tie. This is what this is called. Over here on the left, you see this is like totally normal. This is probably what most of us look like. And then these other two are restricted. The one in the middle isn't very restricted. Um, well, it is. It's pretty restricted, but compared to the one on the right, it's not super restricted. So middle is restricted. Probably this person isn't going to be able to bring their tongue all the way up to the palate. But then on the right, uh, this tongue isn't going to be able to raise above where it already is. So the frenum, just in case you didn't get this, is this piece of skin. Let's see. Can I show you my? Yeah. Okay. So it's this piece of skin right here. This is the frenulum. You have multiple frenulums in your mouth. You've got this one here. You've got one inside your lip here. You've got one inside your lip here. And in fact, I usually wear a mask in class, but if you've seen me at any of the get together things, like we had today, you know that I have a gap in my two front teeth, and the reason I have a gap is because I have a tighter frenulum right here, and so that kind of pulls on that skin and separates those teeth. Um, okay, so this frenulum here, probably this person might be able to get their tongue up a little bit more. This looks stretched quite a bit. They might be able to get it up a little more, maybe not. This person, of course, can get their tongue all the way to the roof of their mouth. And then this one, you can tell, is already stretching against the frenulum. So this tongue is as far lifted as it could possibly be. No way that that tongue is reaching the alveolar ridge. Um, this is basically what I said. Some other problems that go along with this is the peristaltic action. Remember, we talked about this a lot. Using the tongue to form a bolus and then to push the bolus back towards the back of the throat to begin the swallowing reflex. This is disrupted because the tongue can't lift up like it should. Um, okay. Oh, and I thought we were going to go to. Uh, let's quickly look at. Yeah, there we go. So this is the frenectomy or frenulectomy. Again, two words that mean the exact same thing. Frenectomy is an ectomy of the frenum, and a frenulectomy is an ectomy of the frenulum. So basically, what it is just cutting the frenulum. That's exactly what it is. Usually it's done with a laser. Used to be done with like medical shears. Now it's done with a laser. What's great about the laser is it like immediately cauterizes it. So this is the same kid. Here's a really restricted frenulum. Sodium laser comes in, goes across just like a lightsaber, and then here it is 10 minutes later. The bleeding has stopped, it's cauterized, and now there's not going to be problems of lifting the tongue, or there shouldn't be. Occasionally, um, this can regrow. The reason for that isn't that it's it's not like this is I don't know, those things on trees that just keep growing, like the little ones that come out of the roots that you don't want. It's because you have this cauterized skin that's just going to lay against other cauterized skin, and then that will eventually join. Basically, makes an adhesion. So, like, doesn't necessarily regrow a frenum, but it sort of does. It makes an adhesion in the exact same place that the frenum was. It can happen. It doesn't happen often, but it can. If it happens, you just have to have it cut again. Okay, so that's the fix for a restricted frenum. What happens when you have a restricted frenum? I will tell you after I take another quick drink. Okay. So your tongue, the tip of your tongue, should be in this little dotted zone right here. People call this the spot, which I think is a silly name, but it's just right here on the alveolar ridge. This is where you're gonna come up to say like, huh. This is where the T is made. Instead, if you have tongue tie, you're usually down here on the teeth. So you may have some speech difficulties. Instead of saying huh up there on the alveolar ridge, you might say the huh, huh. I can't even do it. But you're on your teeth. So it might sound more like a the where we actually do put the tongue on the teeth. It's an interdental fricative. So essentially you're kind of like turning your alveolar consonant into an interdental. So you have speech sound issues. Not the only one. S's, Z's, all these things. In fact, my S that I have a slight lisp on is probably due to sort of the same thing. It's the only one. All my other letters are pretty much said. Uh, all my phonemes are right except for the S, but for some reason the S is like it's forward like that. Okay. There's also issues with really young children and breastfeeding. So this on the right, on the left, sorry. This is a normal tongue position. The tongue needs to come up to be able to like squeeze milk into the mouth. And if you've got tongue tie, this doesn't happen. So they basically just sit there and they're like, "What? This buffet sucks." And then they're unhappy. So they might have to go to like bottle feeding or something like that. If they get the tongue tie surgery that we talked about, then they can go back to this proper breastfeeding technique, which is great. Okay, this is the surgery we talked about. Another thing that causes OMD is an obstructed airway, usually from allergies or enlarged tonsils. So for both of these, for allergies, you're going to have like inflammation, probably similar to the inflammation that I've got going on right now, but not as painful. Um, and then, of course, enlarged tonsils, this is just going to like obscure the. Do I have a picture of this? Yes, I do. So here's your usual airway. Not very constricted. That's great. Air can move through here and you can breathe. Here, we see that there's some constriction. This could be due to inflammation from allergies, like the pharynx is swelled up. This could be due to enlarged tonsils. Um, Again, inflammation is just constricting the airway. So, what do you do? How do you breathe if you have this constricted airway? one easy way is, of course, to start breathing out of the mouth. Remember, we talked about this. When we exercise, we need more air. So we start breathing out of our mouth instead of our nose. And this is going to be sort of the same thing for people who have chronic allergies or some sort of inflammation back here. I have, by the way, noticed that since I've got this sore throat, I've been totally just breathing out of my mouth like the whole time. I don't even have a plugged nose. I could be breathing out of my nose, but I'm not. And so this is just proof that what's going on is I've got um, sort of an obstructed airway because of the inflammation near the larynx, probably above it and within. I mean, there's probably a little bit of laryngitis going on. That's why the voice is so weird. You should have heard it this morning. It was like I couldn't even talk. Um, so laryngitis, of course, is just like inflammation of the larynx of the vocal folds. Anyway, um, so what you're gonna do here, you can see right here, this is the tongue. This is where the tongue usually sits. And so to alleviate this pressure, you're gonna let the tongue hang out of the mouth. It's not gonna go up here on the top. It's gonna come down, and you're gonna open your mouth and you're gonna breathe out of your mouth. And there you go. This is not a problem if you do it while you're sick, because that's temporary. But if you have chronic allergies or chronically swollen airway for some reason, then this is a problem because you're not pressing your tongue against the palate like you should be. And we're going to talk again. I keep saying this, but we're going to talk about why it's a problem in a second. I talked about this on Monday also, but um, I think putting in the context is good. Okay, so we talked about the obstructed airway and deviated septum is another one. Remember on Monday I said that OMD is kind of like a whole it's like a whole family of symptoms because sometimes it's hard to decide what started all of it. It could be thumb sucking. And it could be that thumb sucking leads to um, anterior tongue carriage. Anterior tongue carriage can lead to mouth breathing, which can then, mouth breathing can lead to a deviated septum. So, can we really say that the deviated septum caused the OMD? Or could we say that some sort of behavioral thing caused the OMD and led to the deviated septum? It's difficult to say. So we know that these disorders are correlated. They don't always all go hand in hand, but they are correlated. So here's a deviated septum. On the right, this is not a deviated septum. This is pretty straight. Nice little septum line here. This is the perpendicular plate of the ethmoid bone. This is the vomer. Um, Here's some nasal concha over here. Just a review for the coming final, if you're planning on taking that. Um, this right here, this is the palate. So here's the teeth, the sides of the teeth right here. Um, like it's the alveolar ridge, but it's the distal part of the alveolar ridge. If you remember, in teeth, the distal part is back towards the molars. So what we're looking at is the alveolar ridge near the molars. So here's where the alveolar ridge comes down. Here's a molar. Actually, this kind of looks like a premolar right here. So maybe we're about halfway through. And then over here. So we're going from uh, alveolar ridge to alveolar ridge, and then we're going to go up to the very top of the palate. And this triangle is pretty flat. It doesn't rise very much. Um, I forgot what it's called. Could be an obtuse angle. I think it's an obtuse angle. Like this is an obtuse angle here. Um, but you can see that it's flat. It's a pretty squatty triangle, is what I'm trying to say. Over here, we've got deviated septum. So you can look at the yellow line here is it's tracing the septum. It gets kind of wonky over here, and then it comes back. The perpendicular plate of the ethmoid bone heads off to the left, The vomer heads off to the left and they meet here in the middle. You can see that the nasal concha are also like bunched over to the sides. There's a couple things that are going to happen with deviated septum. I mean, one thing is it's correlated with greater incidence of sinus infections because look at this. Look at the space. There's not as much space to get stuff out of the sinus cavities. Over here, there's a lot of space. So it's good for drainage. Over here, not a whole lot of drainage going on. So you're going to have a lot more sinus infections. Another thing is this deviated septum means that the palate is a lot higher. And this is one thing that's definitely going to be on your exam. So again, we're going to go from alveolar ridge to alveolar ridge, and then we're going to draw a line up to the top of the hard palate. And this triangle is not squatty. This is a really, well, it's a taller triangle. Um, and that means that this person has a high, narrow palate. A high, narrow palate is a hallmark of two things. A high, narrow palate is a hallmark of a deviated septum, but a high, narrow palate is also a hallmark of OMD. The tongue, when it's laying against the hard palate, is going to act to flatten the palate out, which is what you want. If you have a flatter palate, like over here on the right, then you have more room for the nasal cavities to be open. More nasal cavity um, space, more space for the nasal cavity means, of course, you can breathe more freely through the nose. So you're going to be using nasal breathing more of the time. It'll be a lot longer before you have to switch over to um, breathing through your mouth when you're exercising. Um, Not as many sinus infections, all sorts of stuff like that. And then, all right, that's pretty much all I want to say about that. Let's keep going. So, what happens if you have allergies? What you're going to do is, and this is like a consistent thing, this doesn't just happen in the beginning, it continues to move forward. So, you're going to move the tongue anteriorly, which is going to increase the pharyngeal area. That means you're going to tilt your head forward. So, you can see that this girl has her head forward a bit to help open the airway, and then she's going to breathe through her mouth. But usually, what happens with this is it continues to get a little constricted. So the person has to move forward even more. Why does it get constricted? Because septum is, well, I should say the palate is becoming higher and narrow. So there's not as much air that's getting in through the nasal cavities. All the air has to go in through the mouth. As the nasal cavities are used less and less and less, more air has to go in through the mouth, which then means, which means I have to plug in my computer. Hang on. Success. Okay, so more air has to go in through the mouth, and as more air has to go in through the mouth, you need an even greater open airway, which means you have to lean forward more um, and open the jaws even wider, and just kind of have like a hanging open jaw all the time. Let me go forward a little bit to show you this picture. So here's this opened jaw. The posture you can see this is the same as with that girl, slightly forward to allow for the airway to open a little bit more. The jaw then hangs kind of slack, and what ends up happening is the nose begins to kind of flatten out too, and the chin recedes. Okay. You can also end up having like postural issues with this too, so it can impact the spine because of the way that you're holding your head. This is an orthotropic appliance that is used to move the maxilla forward. So as the maxilla moves forward, and remember that's the bone on the top, that's the one that makes up the hard palate. So moving the maxilla forward can open up the airway in a more permanent way and in a way that doesn't lead to um, like continual changes in the flow of air through the nasal cavities. It's okay that it just pulls the maxilla forward because the mandible will just kind of move forward to meet the maxilla. There's a lot more motion in the mandible, so it's fine. It just moves forward to meet everything. Um, this is a relatively new branch of orthodontics. Some people are getting into this. I think probably in the next 10 or 15 years, we'll see this as um, a more widely used type of appliance. It's sort of like headgear, but different. Okay, so this is high narrow palate. We talked about that. Mm, yes, we talked about this too. Oh yeah, one other thing. Um, Fingernail biting. What? Okay. TMJ pain is another thing that can happen with this, and the reason for that is just the jaw is held open more often, which causes inflammation around that articular disc that we talked about a few sections ago. Maybe it was the last section. I think it was the one before that. There's facial changes that go along with this as well with OMD. So a shortened upper lip, and a larger lower lip, and a receded chin. Um, you also tend to have more mucus and more bacteria. This is goes along with what I said about so increased sinus infections, um, and then also the head and neck are carried forward. So you can end up with spinal and postural issues. Um, I forgot this dude's name. I know the name of his characters in Napoleon Dynamite, but I think his last name is Hader. But it's not Bill Hader, because that's that other guy. It doesn't matter. Um, we know why nasal breathing is preferred because it warms the air, it filters the air, um, allows for more gas exchange. And then here's the problem. I told you that these are the only slides that aren't mine in this entire class. And I don't know who celebrities are. So, um, I don't know. I don't know who these people are. But these are suspected celebrity mouth breathers. And you can kind of see that there's like the elongated. Oh, there goes the voice. The elongated chin and the shorter upper lip going on with a lot of these people. So again, I don't know. I know this guy. I don't know what his current name is, but we'll just call him Sean Combs. It's the only one I know. I also don't think this guy's real. Maybe it's a cartoon of a person, but I don't think so. Okay, so tongue thrust. Here we go. This is what happens with tongue thrust. It can disrupt the flow of the teeth. You can end up with kind of like an overbite in some places. Not a complete overbite, but just of the front 4 or 6 teeth, because the tongue is protruding out where the teeth should go. This can impede eating and all sorts of other problems. Here, down here, this person, this is the reverse swallow. Um, if you ever see somebody swallowing either a drink or food, and they have to do this kind of like pressing their lips together, that could indicate that they have uh, trouble with tongue thrust or OMD, because the tongue isn't able to create the peristaltic motion that you need to be able to swallow. So instead, what they're doing is basically contracting the entire mouth to be able to push the bolus back. So it's an adaptation to be able to eat, basically. Here's some links of videos that you can watch on tongue thrust, but I'll let you do that on your own. This is the high narrow palate. We talked about this. Look at that. That's crazy. That's so. It's so high and narrow. I mean, this person definitely has a deviated septum for sure. Like we said, it decreases the volume in the nasal cavity, which makes it difficult to breathe through the nose. Um, and then it can decrease the entire size of the nostrils because you're not using them, which is what flattens out uh, the nose. The narrow palate also causes tooth crowding, which, you know, luckily I don't have. Yeah, I have too much space, so it's great. This is a celebrity that I know. So Dr. Weinhold chose somebody that I actually know. Oh, I can't think of his name right now though. But he's from ASU, and he's famous for winning in swimming. Oh, Michael Phelps. There we go. He's also famous for being on BetterHelp commercials. Um, so this is a really interesting case study that Dr. Weinhold has done on Michael Phelps because he's, been in the public eye for so long. There's a lot of pictures of him, especially of his face. Also his insanely long arms. Um, and you can tell that there's sort of a reverse swallow going on here. Breathing through the mouth, crowded teeth, and then possibly high narrow palate here too. So one thing that she's done is she has taken pictures of him through most of his career. Again, you can find this dude everywhere. And there we go. So here's the eye line, all in the same place. And then here's the nose line, the bottom of the nose. Nothing should be changing these. It's all going in the right direction. It's the same distance from the eyes to the nose in each one of these pictures. But if you look at where the chin is in relation to all these, it's getting progressively lower. So in this one, his mouth is a little bit more closed. This one's open, but then this one is sort of closed again. So I don't know, this middle one's maybe not the best representation, but you can see from here to here, this is sort of the same face posture. And you can see that the chin has dropped from here to here. And so these are the facial changes that um, go along with OMD. And that's it. Okay. I'm going to record a review, maybe. I might I might just give you slides with a bunch of text. We'll see how my voice holds up for the next one. Okay. Good luck on your exam. And well, no, probably I'll have some. Okay. Anyway, I'll see you in the review video.